Welcome to Oncology Morning Commute, new approaches to testing patients for cancer. Morning Commute is developed by Projects and Knowledge, powered by Kaplan, and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from GRAIL. In this first podcast of our three-part series, Dr. Christopher Mason and Dr. Pashtun Kasi discuss new methods of detecting cancer, including liquid biopsy and blood-based multi-cancer early detection tests. Can one blood sample provide accurate screening for many cancers? Information about the faculty and disclosures can be found at morningcommutepodcast.com/cancer early detect 1. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Mason is a professor of genomics, physiology, and biophysics in the Department of Physiology and Biophysics at Weill Cornell Medicine in New York City. Dr. Kasi is Director of Colon Cancer Research at Weill Cornell Medicine and Director of Liquid Biopsy Research at the Englander Institute of Precision Medicine, also at Weill Cornell Medicine in New York City. I am your host, Candace Hoffman. Dr. Mason will begin our discussion.
Well, hello and welcome. It's really a pleasure I'm joined today with Dr. Pashtun Kasi, who's one of the world's best clinicians and cancer researchers that I know, and many other people feel the same way. So I'm very happy and proud to have him as a colleague at Weill Cornell and at New York Presbyterian. So Dr. Kasi, thank you for joining me for this podcast series. And today we're going to look at new ways for testing patients for cancer, something that's near and dear to our heart, to find cancer earlier and give us more options for treatment, of course. So we're today, first, Dr. Kasi, welcome.
No, thank you so much for having me.
Great. And so actually today we're going to have a discussion like we've had, I think, many times about patients and about technologies, where we today have this ability to test for multiple cancers using a simple blood test, something you can get at a clinic down the street. And I think, basically for today, I want to go through a little bit of where we are with different kinds of testing. What is the frontier? What are some examples from the clinic that you've seen and that you? I know you've just recently presented on this, actually, I think this morning. So we could talk about where is it seeing it be applied, but then also I think it'd be great to think about some of the technology of how it could get better and improve even more. So we'll start first with what are some of the most recent tools you've been using? And I think we can also hit on some recent studies that have come out. But first, what have you been seeing recently in the clinic that you've liked using, and where do you see the field today?
No, it's definitely an exciting area that has sprung up so quickly in terms of having an impact in different phases of a journey of a patient with cancer. A lot of these quote unquote liquid biopsies under the broad umbrella term, they all started with testing patients for advanced or metastatic cancer when the cancer had already spread. But very quickly, it has kind of moved up the ladder. And now here we are talking about tests that can screen for cancer for early detection. I think what I found very sobering, at least as these tests were coming up, is the fact that while there are 50 or more plus cancers, we only have screening ability for 5 or so. And we don't have anything from a screening standpoint for any of the other cancers. So anything that can fill the void in the space will have an impact, or potentially can have a tremendous impact. I think that's only time will tell. But we know for sure from an oncology standpoint and survival standpoint that no matter what type of cancer you're dealing with, there's a sharp decline in survival as soon as you go from early or advanced cancers to all the way from metastatic cancer. So the early stages 1, 2, 3 have a very different 5-year survival or outlook or prognosis than somebody who has stage 4 or metastatic cancer. And the hope and goal with these tests is that we could probably catch whatever cancer earlier.
Yep. I think there's this exciting development where it's now what are called multi-cancer early detection tests, where just with that one tube, you can, as you were just saying, not look at just 1 or 2 possible cancers that would be detected, but really potentially dozens of cancers are screened at the same time. And I think, what's really important also is that for some cancers that are extremely lethal, like pancreas or ovarian cancer, where you often can't see them until they are metastatic, this gives us a chance to try and pick them up earlier. And I think that's, really promising for the field. I confess I recently got a screening test just because I was curious and I was glad I was negative. But then I immediately thought, well, what's the false negative rate? What's the true positive rate? So I think we'll get into that a little bit today. But it's an exciting time where any physician can order it. Usually it's for if there's an indication, but anyone who's even just curious can have this be eventually part of their healthcare. And this has led to some large studies in the UK and in the US. And I think those are some things we'll go into a little bit more shortly. But one of the I think to jump back to that question of false positives, false negatives, we've seen for some of the trials that have come out, for example, like the Pathfinder study, is looking at over 6,000 individuals that are over 50 and trying to figure out what's the cancer signal of origin, where you can look at the fragment of DNA and either by the methylation signature or by how it maps back to the reference genome, you can infer where it's likely come from. And so for those listening, the way you can is because, of course, there's the same genome in every cell in your body because you start as a single-celled embryo, but of course it manifests different as muscle cells, as you think about pancreatic cells, you think about any cell in your body, the DNA is the same, but the epigenetic signature or how DNA is packaged is different and exquisitely unique to each cell type in your body. And therefore, when you take fragments of DNA that are in the bloodstream and you map them back to where the genome, it is a non-random walk as to where those fragments could have come from. Because some cells have open chromatin, some are closed. So the DNA is only specifically accessible in different cells based on where they are in the body and what that cell is doing. So some of these new tools can also give you a signal of origin. So even though it's in your peripheral blood, it tells you where it likely came from. And so we'll talk a little bit about that. But I think what I want to just describe a little bit is, what we've seen, for example, in the Pathfinder study, to start there first, is that they basically detected cancer usually in about 1% of the participants. And of those that they could find it in, about a third were diagnosed with cancer. And of those cases, 71% had cancer types that do not have routine screening. So they would have probably been missed. And that was really, I think, promising, is that we're picking up things that you otherwise wouldn't see. And they mentioned so far in the preliminary results that it's a 97% accurate. So that sounds good. But then there's also a metric for the positive predictive value. So if you're looking for how often are you correct in matching would be a normal clinical protocol, it was 38% or 40% for some of the cancers. So that's lower than you'd like, but the good thing that they reported is a 1% false positive rate. So the hope is that those are numbers that you would have not too many cases where someone's getting misled or having a false positive. But Dr. Kasi, what do you think in terms of what you've seen for false positives, false negatives, some of the metrics of the tests, and what do you think about when you're deploying them in the clinic?
I think those are important aspects as these assays are making their way into clinic. A couple of things building upon what you mentioned. Not only are these assays helpful for diseases where you don't have screening, but even for the ones that we have screening. As a GI oncologist who treats colon cancer, even though colonoscopy is a very effective screening as well as a treatment modality, if you had a polyp, you were able to treat it early before it becomes cancerous. It is a cumbersome procedure. You have to take time off. You have to drink that nasty prep, no matter what the update and no matter how aggressive the advocacy is. Most states have not achieved more than 2/3 of people getting screened. So a third of the patients at most, state numbers are not getting screened or have had the time or for one reason or the other haven't done the screening, even though they know it's important and they know it's part of their care and it should be covered for, it used to be 50 and now it's 45. And we're also seeing, unfortunately, a rise of patients with young onset colon cancer. But in terms of even filling the void, now even for colonoscopy, the stool DNA test came about, but again, simplistically speaking, it's hard to get a stool sample on demand, so as opposed to a blood draw on the way out, or as you mentioned, any clinic that can have this, it will also help to fill the void for procedures or screening modalities that may or may not be as convenient. I was at a conference a few weeks ago, and one of the audience members pointed out that, for her to even schedule a mammogram for screening, it's still probably more cumbersome than given the option if she had a blood draw. So again, it doesn't necessarily replace screening where there is screening, but I think the future direction where it's headed is it's going to be a nice way to build upon as a composite with some other screening modalities. Like some of the studies are combining low-dose CT scan for lung cancer, and they're combining that with an early detection assay. So you're pairing that with the non-invasive blood draw. I think the non-invasive blood draw part is the one that is the most appealing from a patient or caregiver standpoint, and even from an adoption standpoint. The signal part, the tumor-rated part, it brings up issues regarding the signals as to is it truly coming from that one side of origin. One thing that I wanted to point out for the audience is that even though there are many types of liquid biopsies or these detection tests, but also even for the same assays that we are talking about, they've also gone through iterations or next generations or their second or third version of assays. They've continued to evolve and grow and adopt and change, which is great because nothing is perfect and it needs to be streamlined. And as we get more real world data, it is something that they're constantly improving upon. Like initially, very on in the first generation of some of these assays, they were picking up a lot of blood signal from some of these blood cancers, and then they were able to now, with some filtering bioinformatics, able to filter that piece out. Even in the recent studies, they talked about some cancers, for example, cervical cancer being labeled as anal cancer, but the thought was maybe both are caused by the HPV virus, and maybe that's what's causing the signal to be similar. So in some cases, you were picking up another type of cancer. So not necessarily a false positive for cancer, but it was a different type of cancer.
Yeah.
The negative part brings up the question, like you said, if I'm negative, does it mean that I'm good for now, good for a year, good for 5 years? I don't think we have those. I think those are all questions that we need to answer.
Yeah, and there's a lot of good trials that have started again in the U.S. and the U.K., but also more broadly internationally, is taking thousands, in some cases tens of thousands of patients, and longitudinally following them to see what's the essentially presence of some of these mutations, and do they remain and continue to be detected, or are some of them blips, or maybe, potentially could be a short-term lysis of a lot of cells somewhere in the body, but then it got taken care of by the immune system. So it might be something that you don't want to overscreen. Or the example is often was too much screening was done, for example, for prostate cancer, was argued over the past few decades, where in some cases, if you can look at it might be a tumor, but it's not growing, or it might be dysplasia, but it's not necessarily cancer yet, and it might never be, or it might not be for 50 years. And if you're already 80 years old, then you probably leave it be. And so I think some of those questions will be teased out soon. And we're doing some of this even for astronauts, for example, doing cell-free DNA and tracking all of their rare alleles that show up in them over time. And so actually one thing I might jump into a little bit is some of the other one test, and we mentioned the Pathfinder study. There's some of the studies have shown, for example, the sensitivity really depends on the cancer, because it depends on the access of that tissue as well as the tumor to the vasculature, and how likely it is to just be leaving that area where there might be mutations. And for example, uterine cancer and thymus cancer getting really high results, but sometimes if you look at the papers, thyroid cancer has a very low sensitivity, and some gastric cancers can be also low sensitivity in terms of what can you observe that's there. And so I think that is a continued challenge in the field.
One thing that, as you were talking about this, I think for the audience to understand, these are, as one of my colleagues from Georgetown, Dr. Marshall, put it, there's a lot of tumor trash that can make its way into the bloodstream.
Yeah.
And you're detecting different, looking at it through different lenses, so to speak. But the quote unquote shedding of whatever tumor contents in the blood, it's not just simplistically just leaking out into the blood. There is probably some cancer cells that are trying to actually spread or metastasize. Some may just be from regular turnover, and some from just passive shedding. But interestingly, this shedding is very different for different cancers. Like you mentioned, that even for the same assay that's detecting many cancers, while sensitivity for some, what we call like high shedders, we have known about these in our clinic, that even the liquid biopsies that we use for metastatic cancer, we are probably more confident about some of the results in patients like with colon cancer and some of these other liver cancers that are very high shedders. Sometimes we're not as confident interpreting results of an assay in diseases like pancreas cancer and stuff, where there's not much shedding. Not that there's no shedding, but relatively speaking, the shedding is different. And that's where you see a spectrum of sensitivity across the tumor types for the same assay.
Yeah, and I think the other thing that's come up is we've seen a lot of this, the kind of sequencing that you do also can determine what you'll pick up. And so, as I think people in the audience know, there are many vendors on the market, companies that make different kinds of sequencers, and each one of them has its own error profile, has its own, essentially technical limitations, chemistries, also have different bioinformatics tools. So how do you take those fragments of DNA or in some cases RNA or methylation on that DNA? How do you align it to the genome? How do you call it? How do you interpret that data that comes from the sequencing? Depends on the method of extraction and collection and sequencing and alignment and the variant calling. All of these steps can contribute to what you can or cannot see, and that's already assuming that there's a shedding that you can pick up. And so, I think those are all really key factors that have to be brought to bear when making a call of what you have or have not seen. But I think one thing that's really exciting to think about, though, is the fact that many of these cancers, as we talked about before, either had no screening or very limited screening options. And so I think we can start to pick up things in stage 1 or stage 2 cancers, which I think is really the more exciting and really revolutionary part of what these cancer tests are doing.
I still say it doesn't cease to amaze me as to how that's even possible. I've seen the evolution of these assays, and 4 or 5 years ago, when one of the companies mentioned that they could detect what we call minimal residual disease, meaning leftover cancer after somebody has already removed the cancer, I didn't see that something being tangible. And here we are with several assays already in the clinic, even today, that we are doing as part of the regular care as well as trials. It just it's just so fascinating. And with these different types of materials that, like you mentioned, the methylated markers, there are some assays like looking at, fragment sizes, something called fragmentomics, and all kinds of proteins, so there's so many aspects to a cancer that can be detected in the blood of a person, including as early as, stage 1 cancer, or even in some instances, in some series, they're looking at even high-risk polyps that are not even stage 1 cancer yet. That some of these assays are able to pick it up, and there's very good data and large studies ongoing. So it's just fascinating how it is possible and how quickly this has come into clinic as well as practice.
Yeah, and I think it's extraordinary because it's really the stage 1 almost sounds impossible because it shouldn't have its cells shouldn't even be leaving yet, or it shouldn't be shedding at all, because it's by definition just a cancer in one spot. So but the cells continually churn in our body and are born and die millions of times every minute. So it's shedding, and the fact that we can pick it up is extraordinary. And I think, as you just alluded to, we can also begin to pick up things that are early polyps, or even pre-cancers, where you're screening the risk of cancer. And this is a field of clonal hematopoiesis, which we've talked about, where you're carrying mutations that confer a risk in your bone marrow, for example. But you can also pick those up from a blood draw and think about, are you detecting the susceptibility to cancer even before it's coming? For example, for leukemia, is clonal hematopoiesis has been well described as a way to pick up. Are you on your way potentially towards a high risk state for getting cancer? And really tracking mutations in the blood as early as possible, even before the cancer gets there, or the first moment it gets there, is really exciting development for the field. So the other thing I wanted to go over, we've covered a bit of the technology, how you can use, as you mentioned, also the fragmentomics, so everything about how you prepare the sample, the size of the fragment, the presence of mutations, the presence of any modifications like methylation. There's also been new directions that say really these multi-omic tests, where some tests on the market are looking at DNA and RNA and methylation and proteins all within the same test. And so initially, a lot of the work by companies and clinicians in the field and researchers was to just look at the DNA. But I think I'm curious, I know of some of the tests on the market that are beginning to do more multi-omic and multi-cancer early detection tests. But if you it depends very much on the cancer, of course, because some cancers, for example, have a fusion protein that's exquisitely detectable because it's a protein that you never see in a normal cell, so you can pick it up quite discreetly. But I'm curious if you've seen other development of these more multimodal and multi-omic testing to try and pick up cancer.
I think that's where the future is going, because you can identify cancers, or there might be traits of cancers that could be picked up through more than one lens in the same individual. We also see that the same cancer is different in different people. And even in the same person, we call it like intratumoral as well as temporal heterogeneity that can be seen over time, that can be seen in the same person with the same cancer in different parts of the body. One example, for liver cancer, just like for prostate cancer, there's a protein called PSA that can be detected in blood that many people are familiar with. For liver cancer, there's a protein that's called alpha-fetoprotein, or AFP, that can be used. But, in a significant proportion of individuals, they could have the liver cancer but have no elevation of that protein. But in a significant number, on the other hand, can have the elevation. So one of the assays and studies very neatly not only combined some methylation signals, they combined the AFP, because that's also detectable in the same blood that is being sent for analysis, including not only just multi-omics, because they're looking at the methylated signal and the protein. They also factored in the age into the scoring system, which apparently helped with the screening, because there's different sensitivity for males and females for the assay. And that's obviously information that for anybody getting tested, you would know the age, the sex, there are probably racial differences as well that we're barely scratching the surface. So I think it makes sense to go with a multi-omics approach. I think that it all boils down to making it feasible and making it reproducible and bringing the cost down too, because we're talking about screening tests in normal individuals, in people who don't have cancer, not in the small minority who have cancer where you may be using it for different purposes. So at a larger level, I think the bigger question is, what would be considered a reasonable cost for a screening assay that would be for all the ages who meet screening criteria, normal individuals? Is it something that's integrated into a yearly physical exam? Is that something that we do every so often? I think that's where some of the ongoing studies would help decipher the true benefit and what's the cadence that's needed for implementation, and what would be considered a good cost-effective model.
Yeah, this is the big question, of course, for insurance companies and reimbursement and just also resources. Of course, we can't do everything for everybody, but as a simple calculation, say that tests are $1,000. You do it for, say, 50 years, maybe from, say, age 35 onward or 40 onward, then that's not that bad. It's $50,000. That might hedge you against, say, millions of dollars of therapy or treatment. Not to mention, of course, the potential surgery and suffering and just life delayed. So I think, certainly at least back of envelope, it seems like a good argument for some value. But as you just pointed out, though, if you could be even more targeted about who would get the most value, some people might only need to be screened once every 2 years based on their profile and health, and otherwise family history, ancestry. Whereas other people might be higher risk, so they could be twice a year just to really keep an eye on things. And I think the minimum residual disease is also a really exciting area, because for people who are post-therapy who've had cancer, we can really see if there's any bit of cancer left and if it's making a comeback. And as we've seen, with some patients that we've looked at ourselves, when some mutations disappear, new ones can emerge, but you can also track them as well and really see the genetic complexity of tumors as they evolve, as they invariably do.
One additional point that I want to mention, that the field is changing so quickly that these understanding of ours and categorization also is changing for these early detection assays too. While some came with the promise of multi-cancer early detection tests, one test for many cancers, at the same front, there are efforts being also made for assays that are, again, meant for early detection or screening, but are more so for one cancer type. And broadly speaking, as I look at some of these assays, while there might be differences in methodology and stuff, that would be one way of separating out the differences between these tests. One broad categorization is the test specific for one cancer? That, for example, this is only for colon cancer or lung cancer, or is this test suited for many cancers? And not surprisingly, if you're trying to look for many cancers, you may not have the same amount of sensitivity as opposed to if you were looking at one only cancer specifically. So I guess there are pros and cons to both approaches, and it's a good problem that there is more than one way or effort going on in this field.
Yeah, and some companies have really placed a bet on one type of test and one cancer, and so we're going to do it deep, whereas others are clearly going broad. So I think the field is very exciting, and we'll really learn a lot in the next 2 to 3 years as to sometimes maybe certain cancers it really does require that sort of deep dive. Other cancers are just going to be more detectable, so probably could do a lot more multi-cancer detection.
And I used to say 2 to 3 years, but the pace at which things are moving is so fast.
Maybe 6 months. That's right.
Some of these studies with some of these newer technologies, they're doing huge studies of 10,000, 15,000 individuals, and some of them are nearing completion. So I think it's a matter of time where we see more results emerging very quickly.
Mm-hmm. Great. Yeah, it was really great having you on the show, and I think this is really a breathtaking pace of the field, and it's really changing how we can monitor disease, how we can detect disease, and even try and see if someone's on their way towards cancer before it even shows up potentially. So there's these multi-cancer early detection tests are really transforming, I think, what we're seeing for cancer, much like early detection transform how we detect trisomy and other non-invasive prenatal testing, it's called. So it's really changed amniocentesis and CVS, which is now much more rarely done because you can get so much from a blood draw. So here, it's great to see in oncology that we can get so much from one blood draw and really, I think, monitor patients, give a lot of hope for picking things up earlier and then improving how we can see how we're doing after the therapy. So really pleasure to have you on today. And thank you also for the Oncology Morning Commute for hosting us. And everyone have a great commute or subway ride or walk in the park or wherever you may be going.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/Cancer Early Detect 1. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services or download our Morning Commute app. Thank you for joining us today.